Hey there, my name is Greene. I'm a pharmacist and certified functional medicine practitioner. Today we're going to cover vitamin D and all the clinical aspects and best practice uses in outpatient clinic. So we'll cover what exactly is vitamin D, how does it work, and how does it work in various conditions, clinical support uses and benefits, how to give it, testing and monitoring, common side effects and precautions, and then popular clinic protocols. So what is vitamin D? It's a vitamin because it's essential for the body's proper functioning, and it has to be obtained from either diet or sunlight. It becomes a hormone, though, after a series of metabolic transformations that convert it into calcitriol. It's worth mentioning that while calcitriol is an available drug, it's typically only used in patients with kidney or parathyroid issues, preventing the proper metabolism of vitamin D into calcitriol. So vitamin D acts as both a vitamin and hormone that's essential for the proper functioning of the body. It plays a crucial role in maintaining strong bones and teeth by facilitating the absorption of calcium and phosphorus from the diet. In addition to its role in maintaining bone health, though, vitamin D is also believed to have other important functions in the body, in fact, all throughout the body. It's involved in modulating the immune system, promoting cell growth and differentiation, and regulating gene expression. Adequate vitamin D levels have been associated with lower risk of certain diseases such as osteoporosis, rickets, and some autoimmune disorders. While vitamin D is more known for bone health, it actually has critical involvement in almost every part of the body, from calcium management to immune health and many, many other areas. So many, in fact, that we can barely scratch the surface today. So how does it work? So starting with synthesis in the skin, if we're not supplementing, so vitamin D can be synthesized in the skin when skin's exposed to ultraviolet B radiation from sunlight. So sunlight triggers the conversion of a precursor molecule, 7-dehydrocholesterol, into vitamin D3 or cholecalciferol. Alternatively, vitamin D can be obtained through dietary sources or supplementation, of course. In this case, step 1 in the skin would be skipped. So then step 2, we've got activation in the liver. So vitamin D from sunlight or dietary sources is transported to the liver, where it undergoes hydroxylation or addition of a hydroxyl group to form 25-hydroxyvitamin D. This is the major circulating form of vitamin D that's used to assess an individual's vitamin D status. Then in step 3, we've got conversion in the kidneys. So in the kidneys, 25-hydroxyvitamin D undergoes further hydroxylation to form the biologically active form of vitamin D called 1,25-hydroxyvitamin D, also known as calcitriol. So this conversion is tightly regulated by the parathyroid hormone, calcium levels, and other factors. Then we got binding to vitamin D receptors finally, where calcitriol binds to specific receptors called vitamin D receptors, or VDR, located in nuclei of target cells all throughout the body in all sorts of tissues, from the intestines, bone, immune cells, and other organs. And then, of course, in general, we've got regulation of calcium and phosphorus. So one of the primary functions of vitamin D is to regulate calcium and phosphorus levels and placement in the body. And calcitriol enhances the absorption of calcium and phosphorus from the intestines into the bloodstream, thereby ensuring their availability for important processes like bone mineralization, nerve transmission, and muscle contraction. So what form of vitamin D to use? We've got D3, which is cholecalciferol, versus D2, which is ergocalciferol. So D3 or cholecalciferol is synthesized in the skin naturally when it's exposed to sunlight. It can also be obtained from animal-based sources and most supplement forms, which are generally sourced from sheep's wool. Vitamin D3 supplementation is associated notably with better improvements to measured vitamin D levels when compared to vitamin D2. And vitamin D2 is primarily obtained from plant-based sources, such as mushrooms exposed to ultraviolet light, for example. It's not necessary to try to supplement vitamin D2 levels specifically, so just be aware that if you see D2 levels on labs, you shouldn't be alarmed if they're low or even at 0, as long as 25-hydroxyvitamin D is optimal. So various clinical support uses and benefits. So according to a wide study conducted in 2011, roughly 40% of the population has less than optimal vitamin D levels. And many of those have levels in the deficient range below 30 or even below 20 nanomoles per liter. Then, according to a cohort study including over 56,000 people, vitamin D deficiency is highly associated with increased risk of many chronic diseases, from cardiovascular disease to cancer, diabetes, immune dysfunction, neuropsychiatric disorders, and of course, bone disease such as osteoporosis. So with cardiovascular disease specifically, the pathogenesis of chronic cardiovascular disease is affected, of course, by a variety of risk factors, and clinical studies have found that in addition to the well-known ones such as high cholesterol, smoking, obesity, high blood pressure, and diabetes, low serum levels of 25-hydroxyvitamin D are also closely related in occurrence of cardiovascular diseases. In addition to that, specifically hypertension incidence may be tightly related to low levels of 25-hydroxyvitamin D. So its role in the cardiovascular system is very noticeable, since the presence of its receptors, not only around the heart specifically, but the entire cardiovascular system is so prevalent in vitamin D receptors. And the 25-hydroxyvitamin D, the active form, combines and then regulates expression of many of these cardiovascular genes to optimize cardiovascular health. Vitamin D metabolites, they act on multiple domains of cardiovascular function, from those related to inflammation to thrombosis, the renin-angiotensin-aldosterone system, or RAS pathways. Vitamin D is well known to have effects in endothelial cells, where it stimulates nitric oxide production for vasodilation, protects against oxidative stress, and prevents endothelial apoptosis through diverse genomic and non-genomic pathways. So as endothelial function has emerged as a key factor for initiation and progression of atherosclerotic processes, it's been seen that vitamin D may largely contribute for reversing some of that atherosclerotic burden. A broad series of in vitro studies have also suggested that vitamin D and its analogs consistently suppress pro-inflammatory cytokines and actually increase anti-inflammatory cytokines, which mechanisms seem to be related to the inhibition of NF-kappa B and P38 pathways by the vitamin D receptors being activated. And vitamin D also seems to present with anticoagulant activity through the regulation of the expression of procoagulant and antifibrinolytic factors. So low levels of vitamin D actually leads to the activation and releasing of pro-inflammatory cytokines, which then increase the risk of cardiovascular disease by mediating endothelial dysfunction, more arterial wall stiffness, and large epidemiological studies have shown that 25-hydroxyvitamin D deficiency is a large sign and predictor of cardiovascular disease risk. So the mechanisms likely include the elimination of vitamin D receptor by macrophages, which then triggers insulin resistance and mononuclear phagocytic cells as cholesterol, thereby accelerating atherosclerosis. Then we've got diabetes. So low vitamin D levels are highly associated with increased risk there as well. So recent studies have shown that 25-hydroxyvitamin D levels are negatively correlated to prevalence of diabetes type 2, islet beta cell dysfunction, insulin resistance, body fat, and BMI levels. Conversely, 25-hydroxyvitamin D levels were positively correlated with insulin sensitivity and enhanced blood sugar control. So 25-hydroxyvitamin D deficient individuals have a higher insulin resistance and type 2 diabetes risk. 25-hydroxyvitamin D, vitamin D when activated can be combined with the vitamin D3 receptor on the islet beta cells, therefore directly increasing insulin sensitivity, inhibiting inflammatory factors, alleviating chronic inflammation of the pancreas. All of these parts improve islet beta cell activity. Additionally, it also inhibits the action of the renin-angiotensin system, as we discussed before, and this promotes insulin secretion. So vitamin D supplementation can improve islet beta cell function and glucose tolerance. Then studies have found that vitamin D-dependent calcium-binding protein is present not only in islet beta cells, but also in PP cells and D cells, and is most abundant in islet alpha cells. It's primary action is to regulate the concentration of intracellular calcium by vitamin D-dependent calcium-binding protein. Then this affects the endocrine and metabolic processes in various cells of the pancreas. Then other studies have found that glucagon hormone release was significantly higher in islets isolated from 25-hydroxyvitamin D deficient mice than those isolated from mice with normal levels of vitamin D. Moreover, supplementation with vitamin D can make glucagon restore to normal levels in many of these studies. So 25-hydroxyvitamin D deficiency not only suppresses insulin secretion through weakening the islet beta cell function, but also elevates blood sugar through enhancing islet alpha cell function. So many mechanisms going on here where adequate vitamin D is highly associated with lowering risk of diabetes. Then we've got immune system dysfunction, again, highly associated with deficient levels of vitamin D. So it plays a huge role in regulating the immune system, inhibiting inflammatory reactions and autoimmune diseases. When combined with the vitamin D receptor in adequate levels, it plays an important role in immune cell biology. Many immune cells in the human body, such as monocytes, macrophages, dendritic cells, T cells, and B cells, express vitamin D receptors. So vitamin D3 in combination with the receptors in T cells can inhibit the activity of Th1 cells, thereby lowering the CD4 plus T cells that release IL-2, interferon, and tumor necrosis factor. And basically that can suppress the progress of chronic inflammatory autoimmune diseases by having adequate vitamin D activity. In addition, it promotes the differentiation of mononuclear cells into macrophages, strengthens their chemokine production and ability to control infection. It also inhibits the major histocompatibility complex 2 expression of antigen-presenting cells to prevent overactivation of the immune system. So vitamin D also induces beta cell proliferation and the secretion of immunoglobulins E and M. So all these different results overall from studies demonstrate that 25-hydroxyvitamin D has an important role in the entire anti-inflammatory response and immune regulation for the immune system to function properly. Then we've got neuropsychiatric disorders. Once again, low vitamin D levels highly associated with increased risk because, again, remember, vitamin D receptors are all over the entire body, so it affects literally every system of the body. So vitamin D is closely related to metabolism of various CYP enzymes, an activity that's expressed in neurons and glial cells, and especially in the substantia nigra and hypothalamus areas and tissues. So vitamin D receptors, they're highly expressed in many, many areas of the brain and developing brain tissues. So it's suggested that vitamin D may even be critical in development and function of the brain from a very young age, actually. So it's likely that vitamin D participates in a process of neurotransmitter synthesis, inflammation, and calcium balance in the brain. And other studies have documented that vitamin D can protect nerve cells by its antioxidant effects. There was a cohort study that actually included over 56,000 American women between the ages of 50 and 79, and it showed that high levels of vitamin D intake significantly reduced risk of depression, providing additional evidence and suggesting that 25-hydroxyvitamin D deficiency affects neuropsychiatric disorders. And there's a variety of similar studies relating 25-hydroxyvitamin D deficiency with increased risk of depression, Alzheimer's, epilepsy, and neurocognitive decline. So in part of that, the evidence suggests that vitamin D levels could increase calcium binding protein expression, although all the studies couldn't show this. So it can also act by increasing serotonin levels in the brain when there's adequate vitamin D. So kind of a natural way of increasing serotonin and improving and optimizing mood and state of feeling. And it's also been demonstrated to stimulate amyloid beta phagocytosis and clearance by macrophages in Alzheimer's patients, so thereby helping alleviate the pathogenesis of Alzheimer's. So this may explain the association between neurocognitive decline, dementia, depression, and Alzheimer's disease, and there being a high prevalence of vitamin D in those conditions. Then, of course, we've got bone health. The outcomes of vitamin D deficiency in terms of osteoporosis and increased fracture risk is, of course, very well known and accepted. No new news there, of course. Vitamin D is critical in calcium and phosphorus regulation. It's also important to mention here is vitamin K2, which hadn't really been in the limelight until recent years, but it's a critical part of the process along with vitamin D in getting excess calcium out of the vasculature and into the bone, thereby both preventing cardiovascular complications while also strengthening bones by simply helping vitamin D get calcium where it's supposed to be in the body. Then we've got other chronic conditions that are associated with increased risk with low vitamin D levels, and there's way more than we can fully cover here. But just a few other highlights. So vitamin D may be relevant in the pathophysiology of chronic liver disease because its effect on the immune system and its anti-fibrotic effect. So a high percentage of chronic hep C virus infection patients, depending on the study, 46 to 92% actually have low 25-hydroxyvitamin D levels. And more than 25% of those suffering from very severe 25-hydroxyvitamin D deficiency. And in a recent clinical study of adults with non-alcoholic fatty liver disease, it showed that 25-hydroxyvitamin D levels had an effect on the development of hepatic steatosis and in the severity of histological lesions. So a possible role there of vitamin D is also implicated in several other diseases as well, from multiple sclerosis, psoriasis, osteoarthritis, and even chronic kidney disease. So taken together, 25-hydroxyvitamin D levels have some sort of large level of impact on multiple chronic diseases. And another notable benefit, though, of optimal vitamin D that we don't often hear about is the substantial boost in natural male testosterone levels. Several studies, actually, including one large study of thousands of men, showed a 25% increase in total natural testosterone levels in men taking roughly 3,000 international units of oral vitamin D daily. So it really does affect a huge array of conditions and supports against a lot of areas of chronic disease. So now administration options. So intramuscular is the most common as far as injectables goes, most common, well tested, and it's very often done alongside with oral vitamin D and or with K2. I usually recommend when doing oral to combine it with a K2, although we really don't have versions tested, or it's not really well known how K2 would really apply in an injectable. But on the oral supplementation side, combining vitamin D with K2 is generally a good idea. And now a note on IV, not many practitioners try to do this, but just to be aware, giving vitamin D by IV is contraindicated. So since it's an oil-based vitamin, without being micronized or some kind of special formulation that's tested and proven safe for IV, you would never want to do this. So, it could have interaction with blood components. Once it's in the bloodstream, the oil droplets can basically interact with parts of the blood, from red blood cells, platelets, and plasma, potentially forming emboli. So oil droplets, they could coalesce or aggregate to form larger oil emboli, which can, of course, then obstruct blood vessels of smaller diameter, preventing or impeding normal flow of blood. So you would never want to give injectable vitamin D via IV, generally only intramuscular. So testing and monitoring. So 25-hydroxyvitamin D is the blood serum test that is generally done. And it's important to note that most lab ranges note that deficiency is either less than 30 or sometimes less than 20 nanomoles per liter. But that doesn't mean that levels are optimal whatsoever. So, especially since vitamin D is associated with so many chronic diseases and there are vitamin D receptors everywhere in the entire body that affects every organ and every process in the body, it's very important to actually have optimal levels. And that just goes to show that, sunlight is a natural and important part of health overall, and something that we're generally deficient in this world where a lot of us now work on computers and indoors. So the Institute for Functional Medicine actually recommends a 25 hydroxy vitamin D level of 50 to 60 nanomoles per liter as the most optimal level to reduce the risk of the most chronic disease and promote overall health based on available evidence. And again, just noting here, relating back to vitamin D2 or ergocalciferol, you don't need to worry about monitoring those levels. Really, you just need to look at 25 hydroxy vitamin D and see where the actual activity is there. So side effects and precautions. Most commonly with the injection, it's going to be injury to injection site. Other types of side effects are extremely rare. But just some quick ones to note: if vitamin D levels were to actually become toxic, you could have hypercalcemia, kidney damage, bone issues, digestive issues. But generally, this won't happen unless extreme amounts are supplemented for a very long amount of time without proper monitoring. So proper monitoring and looking for those levels, especially 50 to 60, and then backing off to some minimal level of supplementation or just monitoring levels from there. Toxic levels should very, very rarely happen. So now we got some popular clinic protocols. So commonly on the injection side, vitamin D 50,000 units per ml, 1 ml given IM weekly to give a 50,000 unit dose. That will be done weekly for some period of time with tight monitoring. And usually once levels are adequate or getting close in range there, it might be followed by just a monthly maintenance regimen of 50,000 units. And then in severely deficient patients or patients that it's very, very difficult to move their levels, in some of those cases, we might use 200,000 units IU weekly or monthly, followed by transitioning to the 50,000 unit dose either weekly or monthly, depending on the particular patient, how quickly their levels are moving. And then it's commonly done simultaneously with oral therapy, often in the 5 to 10,000 units per day range. And I usually recommend in combo with vitamin K2, because when you really are supplementing this much vitamin D and getting levels up, you're causing the absorption of so much more calcium in the GI that you really want K2 at that point to be the complete part of that cycle. And the 180 mics per day is the best studied dose, and preferably MK7 form, which is a little bit more of a better extended release type of benefit compared to MK4. And that will basically, that extra calcium that's absorbed in the gut at that point can then better be distributed out of the vasculature and into the bones to complete that whole calcium cycle. But it's all dependent on 25 hydroxy vitamin D levels and constant monitoring as to what exactly needs to be done within this. So then we got drug and nutrient interactions with vitamin D. So corticosteroids can interfere with vitamin D absorption. Then you've got anti-seizure medications, which increase the breakdown of vitamin D, so could require extra supplementation in those cases. Then some weight loss meds, as well as cholestyramine, mineral oil, and various antacids can interfere with the absorption, especially of orally supplemented vitamin D. But injectable vitamin D is less affected by a lot of these interactions. So vitamin D in summary, we covered everything from what is vitamin D, how does it work, to various clinical support uses, how to give it, how to test and monitor, common side effects and precautions, and then popular clinic protocols. So it's not only a fat-soluble vitamin, but vitamin D is an extremely powerful hormone as well, with receptors all over the body and all sorts of tissues, and critically associated with lowering the risk of many chronic diseases and promoting overall health. There's very, very few things that cover as many bases for health as vitamin D. And with climbing rates of people working inside at computers and getting less and less sunlight, It's just becoming more and more important than ever to get vitamin D levels checked and to supplement as needed to achieve optimal levels and health. So that includes everything that I'm covering today as far as vitamin D. Here's how you can connect with us, sales at revcustomrx.com. You can call us via phone or check out revcustomrx.com. And here's other ways you can connect with us here. And here is a network of all of our various pharmacies, some of which will supply vitamin D and others not. You can also connect with us on Instagram and LinkedIn. And we have many other trainings that you can check out on our website as well. So if you have any questions about vitamin D or any other products, just feel free to reach out to us, and we'd be glad to help. Thank you.